on the beginning. Does that come up?
Yep.
Can you all see it? Okay.
Yep.
Wonderful.
So we've got Kathleen from Nelson and Gilda MacArthur. Hello.
Nice.
Yeah. So I think we could get started because, yeah, by my clock it is 10 o'clock. So,
okay.
And I think we're in danger of running out of time, if anything. So I think it would be a good idea for us to start now.
Okay.
Helen Sinclair has just said hi. Hi, Helen. So I'm just going to quickly talk to this slide. Welcome, everybody. It's pretty exciting for me anyway. I've not run quite such a big webinar before. We've got about 80 people registered to attend, and I can see Veronique from Waikato's just joined us, which is great. So just to quickly cover some ground rules, people who are attending the webinar just to listen and learn and not one of the five panelists, won't show up on video and we can't hear you. And that is done deliberately so that we don't get a massive amount of feedback and a massive amount of noise. So the only way we can communicate with you is via the chat function, which lots of you have discovered already. Hi Maris, I can see you're there. So if you have a question throughout the presentations, send it through the chat. And I would ask that people only use the chat function for questions, because I'm going to be trying my best to keep up with the questions as they come through, and I'll moderate those and make sure that the panelists get an opportunity to answer those questions at the end of each presentation. I've got my phone here with me. I won't be able to look at it too much, but if you have any major problems, you can text me on the number that I've put on the screen now. And if you're having issues with things like the video dropping out, or the sound coming and going, more often than not it's a problem at your end. I'm not trying to dodge responsibility for sorting out technical issues, but more often than not it's a problem at your end with your internet connection or your sound settings on the computer you're using. So feel free to text me if you've got those issues, but that might be the answer that I give you to that kind of question. So without further ado, I'll hand over to Carmela, who's going to rattle through some slides to sort of set the scene. And
sure.
The order of proceedings from then is we'll then go to Kim, who's down in Southern. Then we'll hear from Julie, who's at Waikato, and then we'll hear from Andrew, who's in Auckland. And we'll answer questions as we go. So,
okay, alrighty. Okay, welcome everyone. And as Gabriel said, really exciting actually to see where this piece of work has come, because we started on this journey a wee while ago, and there's great work that's been going on across the sector. So I'll just rattle off a few slides. I'm the Senior Portfolio Manager here at the Commission, and we've had a slight refresh within the Commission, and I now will be looking after a team called the Community Improvement Team. So my focus shifts a wee bit to aged care, age residential care and primary care, but actually topics like pressure injuries are going to be consistently important across all sectors. So it's pretty exciting to be where we are now, looking at nationally consistent measurement approaches. So just to start off very quickly, the original piece of work on pressure injuries was started by the Commission in partnership with ACC and the Ministry of Health. And we commissioned KPMG to do a piece of work for us. And that was really to try and understand the magnitude of the problem with pressure injuries. And it was quite a big piece of work, and they did a lot of statistical modelling. And the upshot of all that was that they actually came up with through the available data they had, they identified a significant burden on the health system. And they came up with some pretty significant recommendations for a comprehensive pressure injury and pressure management program, which they suggested should be cross-sector and actually span up for a period of 10 years. Now, that was very admirable and very ambitious, but actually at the time, not totally realistic. So the three agencies, which are the Commission, the Ministry of Health and ACC, and I hope there are members of those organisations online, I can't see them all, we agreed to continue the work cross-agency, and each agency took a particular focus for some work. So the two areas that we are signed up to and said we thought were really important were consumer co-design and health literacy, and really trying to arrive at a consistent measurement framework and approach for pressure injury prevalence. And the measurement was really focused on improvement, and Andrew obviously and others are going to talk about that. And it's important to say that there's some great work that was going on across the sector, and we've really built on that. So the Commission's, so what's informed the measurement work stream has been quite a lot of thought. So we formed an expert advisory group. We produced a methodology report that was published in October 2016, and that's actually on the website. We've communicated, well, we've prepared a frequently asked questions document. Again, a lot of thoughts gone into that, a lot of questions from the sector. So we've tried to give as much guidance as we could along the journey. Now, those documents have been published again. They're on the website. It was done in 2017 and also updated in April of this year. And we've been communicating about the development of quality and safety markers through DHBs. We've written letters, we've engaged with directors of nursing, quality and risk managers, midwifery leaders from October 2017 right to the current time. So there's been a lot of thought and process to where we are today. So exciting now to think that we're nearing implementing quality and safety markers, which are going to be predominantly focused in the hospital sector, but we recognise that actually as this rolls out, this is relevant really across all sectors. So the quality and safety markers themselves, there may be some, so I apologise if some of this is repetitive, but if there are people online who are from other sectors, just a quick comment about the quality and safety markers. So the Commission uses them in nearly all of its quality improvement programs. And the way we talk about them is not as targets, you know, they are really to bring about desired behaviour change. And we use them to monitor the impact of our quality improvement work, not ours, but actually the sector collectively. There's nothing here about the Commission doing this alone. We're helping the sector. So it involves the development of process and outcome measures. And in some cases, some of the opioid work we're just also launching involves a balancing measure as well. And again, if you want to know, drill into the details of the QSMs, then go to the website because there is a lot of information there. And they've been mainly...
Oh no.
It's all frozen at Carmela's end.
It's frozen at Carmela's end. Okay. She's in a different room to me. I'll just go down and let her know that she's frozen.
Technology is great when it works. Now she's gone.
Okay. Carmela her whole computer has crashed. So I am going to find the slides and carry on. Actually, Kim, could I hand over to you and we'll get started with your presentation and we'll revisit the slides that Carmela didn't get to?
Yep.
Does that sound okay? Sorry,
Yep,
everybody.
Okay, I'll just bring mine up. Can you see that now? No.
You haven't shared your screen yet, have you?
Share, so desktop. Sorry, we have had a practice, but it doesn't seem to be there.
I'm back. Sorry about that. I don't know what happened. It just went totally dead. So does Andrew do you want to continue, Gabrielle, or shall I keep going?
We just decided to get going with Kim's presentation.
Okay, go for it. Go for it.
I just have to work it out again because it was there, but I had it all ready to go. I've got too many things open. Sorry.
I won't show it now.
Now I'll try again. Am I still there? Oh,
Yep, we can see you.
okay. I'm not sure what's going on here.
Have you got your screen on the desktop, Kim?
Yeah, I have.
And go to your Zoom screen and just go share screen.
I'll try again. Just hang on. Now it's disappeared. It worked perfectly the other day.
That's right.
Right. For some reason I seem to have lost.
Kim, you've just muted yourself, I think.
Yeah.
Oh no, there you are.
Do you want me to keep going while Kim's
Yeah, no,
sorting screen out?
keep going. Sorry. Really
It's
sorry.
okay. Don't worry. It's
Not really sure what's going on.
It is a bit of a mish, isn't it?
Well, I had it perfect the other day. It worked fine. So.
How do you share the screen now?
You need to make this bigger, right?
Slideshow from current slide. Okay, so can you all see that?
Yeah.
Okay, all right. So I'll pick up from pressure injuries, quality and safety markers. I won't dwell too much longer on that, but basically it says that there are two process markers. One is around documented and current pressure injury assessment. The other will be a percentage of at-risk patients with a documented and current individualised care plan. And we've got some definitions around what we mean by that. And again, it's in the frequently asked documentation. The individualised means that in addition to any standard care, which we often refer to as those essential care elements, that the interventions that are put in place in the care plan address any specific risk factors identified in the risk assessment. The outcome is obviously going to be prevalence and incidence of PI, identified by stages through individual skin checks on a designated day of audit. So the next one is really around the collection method. So I won't read what's on the slide, that's self-explanatory and we'll share those, but basically the auditors, through statistical modelling that was done, we arrived at the fact that roughly it's around 5 randomly selected patients per ward or unit per month. And a presentation from Julianne, probably Kim and Andrew, will demonstrate how they have gone about their sampling strategy, so that'll be really good. The number depends on the size of the ward or unit, but roughly it came out to 5 randomly selected patients per ward. There are some exceptions, and they do include patients in emergency departments, day stay patients, patients on the last days of life pathways, in delivery suites, and those in acute mental health units. All other patients we consider should be included in the PI work, measurement work. There is a bit of a question, and there's been some questions around hospital versus non-hospital acquired PIs. And it's important to say that while the focus for the QSMs is on hospital acquired, because that is obviously within your direct control, we are also interested in knowing the extent to which PIs are also non-hospital acquired or recorded on admission. We won't be reporting non-hospital acquired PIs as part of the DHB QSMs, But us and other agencies like ACC and the Ministry will use the information to identify where perhaps pressure injuries are coming from and how we can help and work with carers of those patients in other sectors. For example, we know there are real challenges in age residential care and even in the community care settings. So we would look at whether we should be doing some targeted work in those areas as well. Many of you will know that ARC has already had quite a significant focus on pressure injuries, and that's been driven through Health Cert. The other thing worth commenting here just briefly is that through the National Adverse Event Reporting Policy, the Commission's put out some quite strong guidance that suggests that any pressure injuries grade 3 and above are serious events, and really we would like to have more visibility of them through the National Reporting Event Policy. So the timing, and this probably brings me almost to the last slide, and then we'll move on to Kim. The timing, really a lot of preparatory work's gone into working with pilot sites, and that's been done across an engagement across the sector. Data collection by DHBs will commence from the 1st of July 2018, so that's really exciting. And that's the first quarter of reporting from July to September. Submission then comes into the Commission the following quarter. We've made a general agreement, and it's been communicated to the sector that the first 2 quarters of data will not be publicly shared. These 2 quarters are really treated as pilot or implementation phase, particularly for those DHBs who have not been involved in any of the work so far. And at this stage, the first quarter of data that will be made publicly available will be that's collected through the January, February, March 2009 quarter. And that will be reported probably mid of the next quarter. So really published in about May, June 2019. So that's really my spiel, and I'm sure there'll be questions, but we'll hand over now, Gabrielle, to whoever's next. Is it Kim?
Yep, Kim, have you managed to sort whatever issue?
I think so, hopefully. Desktop. It's just not showing up. Oh dear.
So you click on share screen, which is at the bottom. Yep. Yeah. So you've started sharing your screen.
There we go.
That's it.
There we go. Now we're good.
Okay.
So now you just need to put it into slideshow view, and away you go.
Is that right? Hopefully.
Yep, that looks good to me. We're seeing it, and we can see your next slide and your notes. So.
Okay.
Yeah.
Oh well, we'll just leave it so that I don't muck it up yet again.
Sure.
Is that okay? Okay. Yeah. So just really going to work through with what we've been doing in Southern. From our past measurement approaches perspective, we had previously done pressure injury audits on the Otago and Southland sites. So we've got 4 sites that we have responsibility for within Southern DHB. We had done no pressure injury audits since 2013, and we had no joint data collection across Otago and Southland. In 2016, Health Roundtable data showed that we had an increase in the numbers of stage 3 and 4 hospital-acquired pressure injuries, and also a review of our Safety First, which is our incident management system, showed that we had differences in what we reported versus what was coming through in other data that we were looking at. So we knew that we needed to do something, and quite opportunistically we had the opportunity to participate in the Health Quality and Safety Commission program. So in Southern DHB we use the A3 improvement methodology, and that's the methodology that we adopted, so I'll show you that in a minute. We developed an audit tool. Key focus was on keeping it as simple as possible, really looking at keeping it true to what we were trying to capture, as opposed to trying to make the form cover lots of different methodologies or lots of different data collection points, because if you make it really complex, it's really difficult for staff to buy into and comply with. And we made the audit process as streamlined as possible. From an audit process perspective, we have adopted what Auckland do, and Andrew will talk to that shortly, but pretty much we have the first Tuesday of every month is our point prevalence audit. we run the random NHIs through a randomizer, and then that's sent out to all the wards, all the participating wards. We have successfully brought on all the adult inpatient areas in Otago and Southland, so Med-Surg, AT&R. We have also brought on neonatal unit and children's ward in Southland, but we've got ongoing work to do with children's and neonates and acute mental health, or not acute mental health, but long-term sort of mental health areas on the Otago sites. So that's one of the questions that has come up for us and is under debate, is what constitutes acute mental health versus what's sort of a longer term facility. So I print the list, and then what we've found really beneficial is that I actually do a walk around, and there's someone in Invercargill that does the same, does the walk around to the clinical areas. It's really difficult to get something that becomes business as usual really quickly. And so what we've found is the benefit of the ongoing prompting. We send an email out the day before, and then I deliver the NHIs along with the forms to make it as simple as possible for the areas to complete. We've had a really high compliance with completion, so I pretty much get things back the following day, which is the process that we've put in place. Which enables us to sort of complete the audits within 2 days really and get results sort of compiled. We've only been doing it a short time, so we haven't been sharing individual ward data. Our focus is on capturing organisational data at this particular time. So this is a completed A3, and as you can see at the top, it says version 27. And what that means is that it's taken us we started about this time last year, and so it's taken us a year to develop the process. And you can see on the left-hand side, you spend most of your time on the left-hand side trying to nut out your problem, look at what your processes are, and identifying what the opportunities are for improvement before you move to your right-hand side and really look at your implementation. So certainly by the time you get to implementation, it should be reasonably straightforward because you've done the sort of due diligence in your project methodology. The results, you can't see the graphs very well, but what I'm demonstrating there is that we're capturing data now. We've got information that we can share with services. We've got 7 data points as of this week for our monthly audit for hospital-acquired pressure injuries. And as soon as we have enough data points, then we will start popping that into a statistical process control chart so we can look at our upper and lower control limits, etc. We have Safety First, which is our incident management system, and there's just a couple of examples there of what we can pull off the system. So stage of pressure injury and reported SAC score are 2 things that we have got there. Pretty much anything that's reported into the system we can pull out, so it's just a matter of looking at what's going to be meaningful moving forward. Our audit tool, what I've shown you, that circle in red, is pretty much what the staff need to complete. So the purpose of this is to really make the tool as simple as possible, and it's basically a skin check. So the expectation is that this is the documented skin check on the day of the audit, and this goes into the patient file, so it can become part of the documentation, but is also scanned through to me so that I collect that data and put it into a spreadsheet in order to have an organisational view. So we've tried to sort of keep it quite streamlined. We've got the exclusions on the front. We've got the incontinence associated dermatitis with the visuals because people do get confused about that. And then we've got the grading on the back so that we can just prompt and remind people what the grading looks like from a skin check perspective. And we've got pretty good compliance. We've taken, I think this is about version 9, and pretty much the testing's been, let's test it out, let's see how we fill it in, and then let's start to see how they can how they respond and how I can interpret it really when it goes to putting it into the database. So I think we've got a pretty good form now that seems to be capturing what it is that we need. We've got a really simple flow chart for the documented process that starts the day prior to audit when they get an email reminder saying that don't forget we've got our audit process tomorrow, and then what is followed, it sort of outlines the responsibility is with the charge nurse managers to make sure that the audits, the ward's prepared for the audit, and then they check the forms before they return them to me. We've only had 1 month where we had a problem where NHIs, etc. were not recorded, and so we just took that opportunity, reminded people what the process was, and we've had no problem since. On the back of the form, it's got how many audits are conducted, and again, that's using the same methodology that Auckland uses. So 1 to 10 patients on the ward, you select 3 patients randomly and 2 audits are required. So just as an ongoing reminder for staff, we've got some complexity where we've got wards that are really small, and then we've got wards that are super wards, so they might have 40 to 50 patients just because of the configuration. So from our perspective, key lessons learned, you need to keep the audit process as simple as possible. We've really worked hard to build it into sort of the care that people are delivering on the day, and it's just a slightly different format for documentation on that particular day. Don't underestimate the support required to establish the audit process. As I said before, I still do the walkarounds. We've been doing this now since September last year, and it's certainly still not business as usual. And I think that support is required ongoing for some time yet. It does need some form of centralised coordination. So when we started out, the question was, how are we going to sort of pull all this together? And the reality is that it does sit within some sort of quality environment in order to pull it together and continue to work on and refine the process. You really need to look at how your data will be collected and collated. It's an important part of the project, but again, keep it as simple as possible. Don't make it too complex. Keep the initial focus on the Health Quality and Safety Commission markers, because if you try and solve all of the problems of the world, your project will become really difficult and insurmountable. So for us, it's still early days. We've still got a lot of work to do around pressure injuries. It can become overwhelming, and my key advice would be establish your audit process first, and other things start to follow in relation to that. As I said, not all areas are participating, so I've documented them there. And at this stage, we don't have enough data really to share back with individual areas, and that's not our focus. Our key focus is having a regular sustainable process for auditing. And this week we've got 9% hospital-acquired pressure injuries for our point prevalence audit. So we have just completed the June data as well.
Glenda Dagger had a question about the random selection of NHIs.
Yep.
Being either, was it from all patients or those with existing pressure injuries? So I just want to quickly interject and make sure that everybody realises it's the entire patient population.
Yep. So we have a tool in our reporting system that's a patient randomizer. So basically I can just go and plug in the date, the ward, and it randomizes, and I say how many patients I want pulled from that total population at that time, and it'll just give me whatever number I ask for.
Yeah, and you had your sort of business intelligence or business analysts help you to do that, didn't you?
No, that was a pre-existing report on the system for other reasons.
Oh, okay. Well,
No, I was just lucky I knew it was there. So I've already talked about reporting, so I won't go into that again. Further actions that we have really around essentials of care. So one of the things that we're finding is that whole need to sort of link up patients at risk, so they have risk of falls, risk of pressure injuries, they have nutritional issues, etc. So that sort of gets bundled up into the essentials of care and how we're documenting that. And as an organisation, there is a project that's sort of starting to get underway looking at that. So that flows into documentation. Education, of course, is an ongoing gap. Just with the point prevalence audit this week, there was a couple of patients of concern that I've just done a brief clinical review on, and further things that we need to sort of look at. We have a patient safety group which provides governance to a lot of this patient safety sort of stuff in relation to the commission work, but also broader. So reporting goes through there. And certainly huge opportunities with the broader project to implement the guiding principles for pressure injury prevention and management. So we're very much at the very starting point of our journey, but it's great to sort of have worked through and developed a robust process, which I have to say I've applied to other clinical projects that I'm involved in as well, just using the same methodology. So that's awesome.
Nice.
And that's Sharon and I are both available for any questions that people may have. So
we've got one more question that's just come through. Has Southern started looking at the age, gender, ethnicity of individual level data collection?
No, not specifically. I've got echo now.
So do I.
Not specifically. We haven't gone into that level of detail. We've only got 7 months of data, so it's very early stages. Yeah.
Well, just in the interest of time, I'll get Julie to share your screen and we'll move on and hear from the Waikato experience. Carmela, I might get you to mute yourself. I don't know why we're suddenly getting an echo. Yeah, I'll mute myself as well.
Can you hear me?
Yes, we can. Yes, we can, Julie.
Excellent. So I won't spend a long time on this slide. I'm just going to cover how we got on this road of measuring pressure injury prevalence. So quite a number of years ago, around about 2012, our major source of reporting pressure injuries was via incident forms, which everyone knows is an unreliable source of data. We also had some information from the Health Roundtable data at that time that indicated that our number of pressure injuries were on the rise, and particularly grade 3 and 4. We'd had 3 serious events that involved stage 3 pressure injuries. And we'd also undertaken a pressure injury care audit across the organisation around reviewing risk assessment and associated care, and found that we had some issues with the link between undertaking a risk assessment and implementing a care plan that managed those risks.
Julie, I'm just going to ask you to speak up, please. We've got a couple of people saying you're a bit quiet.
I'm going to have to almost kiss the computer now. We also had undertaken a small hospital survey, but that was resource intensive, and we couldn't do it frequently enough for the results to be meaningful. So we had a problem, and what did we do from there? Well, actually, I went and talked to Andrew Jull, and we drew together a group of people from the organisation to discuss this, and we decided to do a pilot project so that we could really have a close look at strategies we implemented and make sure they worked before we did anything across the organisation this size. So what are our current measurement approaches? We do a random sample the first Tuesday of every month. The sample is drawn from the Midnight Hospital census, and the census includes Waikato Hospital and all our district hospitals, and Rotorua and Matariki, which are 2 continuing care units that we have. It was actually difficult to work out how to randomly sample patients due to disparity in ward sizes across our sites, and we had a business analyst help us to create a reporting system that randomly selected patients, which was actually quite a huge thing in terms of supporting the measurement. Our sample size, as you can see below, is if we have more than less than 11 beds, it's 3 patients. 11 to 30 beds is 7 patients, and greater than 30 beds, 10 patients are measured. but it averages out to 5 patients per ward, and we have reserves on each list, which means if our patients are off the ward at that time, we can still get the sample that we need. We measure all adult wards, but agreed exceptions, which have already been discussed, but we're currently doing ongoing work with neonates and paediatrics to ensure that we're developing systems that are going to meet the specific needs of that population. And we measure process and outcome data, which is around compliance and obviously hospital-wide prevalence. So what did we learn? We learned that leadership at a governance level is crucial. And we got approval from our Board of Clinical Governance to proceed with a full rollout of the pilot project once the pilot project had come to an end. We also set up a pressure injury measurement steering group that was made up of influential people across the organisation that could drive change, and that included our Director of Nursing, Director of Quality and Patient Safety, nurse educators. There was myself as a nurse practitioner and a patient safety facilitator who kind of coordinated the whole project. The other thing that we learnt was phasing in across areas is really important. Take the time to plan and implement and engage the clinical areas so that people are more likely to get on board with the change. We also found it was really important and started out with the understanding that we really needed to listen to staff concerns and understand what their biggest tension was in managing pressure injuries and what their knowledge base was around that, because different clinical areas have different tensions around pressure injuries, and we really needed to get people on board and understand their reality. So they got something, we got something. Get help to generate random sampling and centralise reporting. That's really critical to success and ongoing sustainability for this kind of project. We had a dedicated FTE to facilitate the program, which was a 0.2 FTE and a patient safety program facilitator who coordinated the project. And the other thing that we learned, because if you're rolling out a project this size across a big organisation, it took us about 18 months to 2 years. We needed to go back to the start, because you just can't implement something like this and then let everyone just assume that it's going to run smoothly forever. So we learned that to go back to the start, go back to those wards that start, re-educate and sustain it so that it can become business as usual. So what were our results? So this is a run chart from our results from 2016. We've actually been collecting results from 2012, but I couldn't work out how to combine those two charts. So you've got the latest, which is from the 1st of May 2016 to the 1st of May 2018. So this is a run chart, and it's reported to the clinical nurse managers across the organisation, the Wound Care Clinical Governance Group, and discussed at the DHB Patient Safety Group. Our initial target was 6%. I believed if we could get to 6% pressure injury prevalence, we'd be doing well. And you can see that our target on this side is now 2.5%. When we started, we had a prevalence of between 10 and 12%, so we've done quite well. The project was rolled out across all inpatient wards across the DHB from mid-2016. So now we've got about 2 years of data that's giving us some confidence around what we're collecting. Our current hospital-acquired prevalence rate is 4.6%, and our total prevalence is 6.4%. You'll see we had a blip in 2017, and that was an increase in stage 1 and 2 pressure injuries. And so we had a quick, well, we didn't have a quick look. We had a look at the things that might influence that, and what we discovered was our patient demographics, and all our data indicated there was no change in anything. And what we went back to was to look at our equipment, and our current standard hospital mattress is a high-spec foam, which was probably about 7 years old, and so we're looking at a way to change over that stock and review it on a yearly basis. So we also collect other information with our prevalence injury audit, and we also know that we've audited 4,156 patients so far. Our most common stage of pressure injury is 1 and 2. The most common site is sacral. Once you hit over 70 years of age, your prevalence increases with each decade from 4.6% up at 70 to 6.3% at over 90. We also collect data on ethnicity and, as you know, age, otherwise I wouldn't be able to share that last piece of information with you. So, what do? We review our prevalence at a governance level. We look closer at risk areas and management strategies to try and reduce that risk. We've developed a contributory factor list to assist with serious event reviews for stage 3 and 4 pressure injuries. As I said, we're reviewing our mattress stock. We work with high-risk populations, so we've gone back to vascular orthopedics and areas that have frail elderly and look at where they're getting pressure injuries and what we can do to try and reduce that risk, and re-educating and sustaining on an ongoing basis. The other thing that we're looking at is trying to figure out how we can capture community prevalence and work with other areas where we've got frail elderly that may be coming in with existing pressure injuries. And the other thing that we've done is develop something that recognises wards commitments. So wards that are doing really well in terms of compliance receive a patient safety award. And I think that's the end. Yes.
Thanks very much, Julie. Chat has gone a bit silent, so I'll just reiterate, and I'm getting terrible echo, I don't know why that is, that if people want to ask questions, they can use the chat function, and I'm moderating those. So please do answer any questions that you have, but if there aren't any questions, we'll go to you, Andrew.
Okay, thank you. So I'll just start up sharing screen. And hopefully that has come up. Okay, so I'm Andrew Joel. I'm a university professor at the University of Auckland, but also a part-time appointment as nurse advisor for quality and safety at Auckland District Health Board. There's my email address there if anybody wants to get in touch with me. I would point out that I'm on sabbatical for the next 5 months, starting late June, but I'm happy to continue monitoring email for questions around pressure injuries and this particular piece of work, the measurement project. Okay. All right, so in the past, as Julie mentioned, we've similarly used self-reporting processes via Risk Monitor Pro to try and understand what our pressure injury prevalence was. That's widely recognised to be associated with underreporting. We've had the occasional whole of hospital survey, which we identified as being too infrequent to support an improvement approach, and also required an enormous amount of effort to do whole of campus surveillance on 1 day per annum. We've also been strongly involved with releasing time to care, and within releasing time to care there is a monitoring process called safety crosses, which people have used in the past. And there's a real problem with using safety crosses is that they only show what's happening over short periods of time, for instance a month, and that again doesn't really support long-term engagement with a project like pressure injury prevention. So we, in early 2012, as part of First Do No Harm in the Northern region, established an approach that involved a random sampling on the first Wednesday of each month, and that's drawn from the Midnight Census, and the sample list of patients per ward is sent off to each ward at 6 o'clock in the morning. We've automated that process so that the list is automatically generated and the audit forms pre-populated with patient information are sent to ward printers. And also on that list, which on average is about 5 patients per ward, but like other areas, we have small wards and large wards and what have you. So we do have a varying sample size on the basis of the ward size. But on average, it's about 5 patients per ward per month, which means we collect approximately 230 to 250 pieces of information from the hospital per month, giving us around about 2,700, 2,800 patients per annum. All wards, bar delivery suite, emergency departments, and our acute mental health unit participate. We also encourage wards to exclude patients who are on last days of life, and that's why they have reserved names on their random sample. We use this process to collect both process and outcome information. So we collect the information on assessment and care planning, as well as the skin check results on the same form. And we also use that, we've integrated that with the QSM collection for falls that is reported to HQSC each quarter. So we've tried to minimise burden on data collection wards by amalgamating processes. We did this all in one hit, and if anything, I would suggest that people should phase implementation rather than try to do measurement all in one go. We did employ people to support this process. So we had a project manager in the first year to put this project together. And wherever we could, we automated. But that said, I mean, we're reliant on snail mail to get our information back, and that sometimes fails us, particularly over Christmas periods. It's remarkable where mail gets redirected to. We report the process markers back to wards, to all wards. They all see each other's information as well as their own information in order to promote a little bit of competitive spirit. But the outcome marker information is only reported across the DHB. We don't report that by ward because there's not enough information to be useful at a ward level. We have very much focused on what we control. So it's our belief that most pressure injuries that are created within a hospital environment are avoidable. Not everyone, but most of them. And therefore we have focused on collecting information about hospital-acquired pressure injuries. This is our prevalence rate. This is a statistical process control chart produced in Minitab. Along the side here, you can see the proportion of patients. This is convertible to percentage, so 0.08 as a proportion is 8%. And that was our average prevalence across the period up to the point we had our first step change. And you can see that our first step change didn't occur until we had been well into the process, probably around about 15 months into the data collection process before we got a clear signal that we were starting to reduce pressure injury prevalence. We reduced it from that 8% to about 4.5%. Which was sustained over quite a period of time, but we did, good heavens, what's happened? Sorry about that, but we did pick up again another signal that we'd had a step change around here in July 2017, and our current prevalence rate is around about the 2.5% mark. The real background to what this chart really demonstrates is that this is a long-term process. Each of these blue dots here is a month of data collect, although it's reported by quarter across the x-axis. So, big picture, what have we done? We've had very high-level governance. Our Chief Nursing Officer leads the governance committee for the project. We did have support for 1 year to put this process into place, and that wasn't just the measurement process, it was also improvement activity. We did have a policy, but we revised that based on the S-Skins bundle, although we called that A+ Skinny. We had a variety of assessment and care planning processes in place, which we standardised into a single process for adults and a single process for children. We did put in high specification foam mattresses across the entire hospital around about 2013. We made it easier to access support services around about 2013, 2014. We made a commitment from 2013 that we would investigate any hospital-acquired stage 3 pressure injury or stage 4 pressure injury, and the wards themselves investigate that using a multidisciplinary case review framework. And that is then reported up to a adverse event review committee. Again, the chief nurse sits on that committee. We've introduced something called a concept ward where we test bed solutions. That's undertaken in a vascular ward. But most importantly, this has been a continuous process for us. We have not disengaged from this process since 2012. And I think that that is the key to this. It is a long-term process, and maintaining engagement through regular measurement and review of what the data is telling you is a useful way of improving on performance. And that's me.
Thanks very much, Andrew. We've got a few questions. Going right back to Julie, actually, because I'll start at the top. Julie, Francis from Nelson Marlborough, who's obviously got eagle eyes, spotted that diabetes isn't included in your risk assessment?
It is.
It is.
Okay. There's a question in the first part of the risk assessment that asks if people have at least 2 of the following comorbidities, which includes diabetes, peripheral vascular disease, and hypertension.
Great, thank you. The next question from Glenda Dagger, is the prevalence data based on random selection or all HARPy reported? The prevalence data is based on the random selection, and all hospital-acquired pressure injuries, including stage 1, are reported. Yeah. Somebody's asked the question about how you go about getting dedicated FTE for this. Is there any tricks?
No.
Kim's responded to that quite nicely.
Yeah. It is. Skin checks should really be part of business as usual. So it's just the audit that's in addition. I'm getting terrible echo, so I'm trying not to talk too much.
I think the echo comes when more than one person is open, because I noticed that if everyone else closes, it's better.
Yeah. Dawn French to all panelists, how did you inform patients? So
it's Kim here. We did have that discussion around informed consent versus implied consent as part of the national program of work. And I mean, in reality, we should be doing a skin check on our patients. It's part of our patient care. The way in which we document it on the first Tuesday of the month may be slightly different, but in fact, it is a nursing assessment. It's reasonable to inform people, because some people that you are doing a skin check on have been randomised and they might be pretty fit and up and about. So it's reasonable to inform them about why you're doing it, and talk about it from an improvement perspective. However, there doesn't need to be any documented consent. There is a level of, you've come into hospital, it's part of how we deliver your care, and it becomes an implied consent.
Thank you very much, Kim. Anybody else got any other questions? I think I've covered them all off.
Thank you, Gabrielle. Mine's just an observation, really, and I suppose there's some fantastic work going on. So we've talked a lot about the measurement piece, and obviously the pilot sites that have spoken about their work have an ongoing pressure injury prevention and management program, but that obviously is a key area, and as Andrew's touched on, this is long-term, it's continuous improvement. So it's worth people thinking about what is their patient safety, nursing, multidisciplinary commitment to the ongoing improvement program that you need running alongside your measurement as well.
So I did have a question. Oh, sorry, am I muted? No. I did have a question earlier from Cheryl. I'll just go back and make sure I found it. Asking about the data submission tool. So just so that everybody who's online knows, we did send the we've created 2 optional data submission tools for hospitals to use, and we also realised that possibly you've already got your own data collection methods, so we didn't want to come in over the top of those. But at the start of April, I sent them out to the quality and risk managers, the DONs, and the midwifery leaders. So somebody in your organisation does have them, but I can resend. And the 2 options are, one assumes that you've already got a data collection tool, so it's just to transfer the numbers from your existing tool into our submission tool, and then you send it through to the commission. And then the other option assumes that you don't have a data collection tool, and it's a line by line, patient by patient, enter their age, gender, ethnicity, and the quality and safety marker data. And we wouldn't want you to send us that page. The next page summarises all of that for you, and that's the one that you would submit to the commission. But Cheryl, I will email those to you, so you've definitely got them. Other people, if you can't get them from your quality and risk manager, or it's got lost in people's inboxes, just email me and I'll send them out. And I'll make sure they're up online as well, so that people can access them from multiple locations. So that should cover that off.
Gabrielle, there were a couple of advanced questions that you signalled you wanted me to answer.
Yes, please.
Okay. So we had an advanced question from Paula McKinnell at Cap Coast with respect to how avoidable versus unavoidable PI are managed when all PI is given in a timely manner. With respect to the measurement process, we don't distinguish between avoidable and unavoidable. We simply distinguish between hospital acquired and non-hospital acquired. But when it comes to looking at serious harm pressure injuries, the stage 3, stage 4 pressure injuries, and we also put unstageable in there as well, we do examine ask the investigators to examine whether the pressure injury is likely to have been avoidable or not. And that's really signalled through all the questions that we encourage people to ask of themselves. And there are some instances where we have found that despite all the best measures, the pressure injury, serious harm pressure injury, has not been able to be avoided. But that has to be understood within the context of that particular patient. So most of those patients have been intensive care patients. Virtually all of them have been on ECMO. A number of them have been children. And the fact that they're on ECMO and that they are really, really seriously sick means that we're really trying to perfuse them centrally, and it's the peripheries that get damaged as a consequence. And so we would in that instance accept that that was an unavoidable pressure injury if they'd taken all measures to try and avoid a pressure injury. If, of course, they hadn't taken all reasonable measures to try and avoid the pressure injury, then even in those circumstances, we would consider it an avoidable pressure injury. So, you know, it has to be thought through carefully and talked through with the investigating team. There was another question. I hope, Paula, that answers your question. There was another question, again, with respect to the pressure injury reporting method. Does it include recognition of body mass or obesity status? And I guess that arises from the potential that, particularly if people are underweight, they might be at more increased risk of pressure injury. And with respect to individual DHBs, with respect to the data collection method, no, again, we don't ask for information around patients' weight or BMI. If an individual DHB wants to collect that information, that they can make that decision. But from HQSC's perspective, there's not the intent to distinguish between people on the basis of weight. Are there any other questions you want me to answer, Gabrielle?
No, those were the only two that came in advance. I'm just aware of the time. We've just gone 11:01 at my end.
There was one from Emil, so he's asked Andrew about the significant drop on 2013-17. How did you achieve that?
Oh, thank you. Yes, I missed that.
There's no magic bullet. It's just play the long game, keep going, keep going, keep going. It's, as Julie mentioned, you know, when you see something that suggests you have a problem, re-engage, and you know, just keep on working the problem. That's the magic bullet. There's nothing that we particularly did that led to that change.
Okay, well, oh, there's one new message. People are sending them in. We might have to say goodbye, and any further questions can either be emailed to the individual panelists who gave you all their email addresses, or to me, and I'll pass them on. I'm about to get kicked out of the room that I'm in, you see. But thank you very much, everyone. At the peak, we had about 65 participants. And I can see the number dropping down now. There were 40 people are signing out. So we'll end the meeting. Thank you very much. I hope everybody found it really useful. Feel free to get in touch. And thank you very much to the panelists. Bye-bye.